Now it's my pleasure to introduce a good friend of mine, Randy Kojima. Randy is the Clinical Research and Development Director for Precision Technology, which is based in Vancouver, Canada. He also serves as a research scientist and clinical instructor at the Pacific University College of Optometry in Oregon. Additionally, he's a clinical advisor to Medmont Instruments in Melbourne, Australia. He's published numerous articles, submitted posters, written books, book chapters. I mean, Randy is the best of the best when it comes to topography. And not only is Randy incredibly smart, but he is able to convey the information to people in such a wonderful way that we always have so many comments on how great of a presentation that Randy gives, and people are always delighted to hear from him. So Randy, thank you so much for being here.
Oh, thanks, Steph, and what a pleasure. Thanks for including me in this awesome session on myopia control, orthokeratology, and changing our practices. It's really exciting to be here. Before I begin, my financial disclosures are I work in industry in numerous capacities, and these are my disclosures. Steph asked me to speak on corneal topography and orthokeratology. So let's talk about how we use this tool, both pre-treatment and post-treatment, to best help us through this entire journey. And for many of you, the topographer might be a brand new instrument to your practice. So if you're kind of intimidated by it, I wouldn't be surprised. There's a lot that it gives us, and I know personally that I felt that it was information overload, that I didn't know what to use and when, and that really was a problem. And having some mentors in this journey is really valuable. At least for me, it was talking to some experts, getting their idea of where do I go pre-treatment? What do I look at? And what analyses options are useful? And which ones should we just, leave aside? And the same thing with post-wear. How do we understand the changes we've made in orthokeratology? So Steph's given me this great opportunity to be able to share some of these thoughts with you. So let's begin. We have a right and left topography on this patient. We are thinking about orthokeratology as the preferred myopia control tool. Now, what do you look at in this topography that determines for you this is a good candidate, or maybe this is a candidate better served in soft multifocal, or as Nick said, maybe atropine for this particular patient is the right call? Well, let's look a little deeper. Now, there's all of this information that the topographer gives us, and sometimes your screen is just filled with analysis, and that totally intimidates me, at least. So what do we look at that's going to help us through the process? And of course, we are so comfortable with K readings and the corneal astigmatism, and certainly that's a guide. Is the corneal astigmatism 1.5 diopters or less? That's considered a very good candidate. If it's over 1.5 diopters, it's a little more of a challenging case. Now, another consideration is ortho-K has been shown to be very relatively easy on steeper corneas relative to flatter corneas. So in other words, if you have a high RX and a steep cornea, you're a little more inclined to tackle that case. If you have a high RX and a flat 40 diopter radius cornea, that's a little more of a challenging ortho-K patient. The epithelium may not move as easy and as quickly as you'd like it to. Another thing that you might look at is the eccentricity of the eye. It's been shown that the higher the E value, the better the cornea responds to ortho-K. The flatter the cornea, the less well it responds to ortho-K. So thinking similarly to radius, steeper corneas respond very well. Higher eccentricity eyes respond very well. So your kind of worst patient is your flat, low eccentricity eye with a higher RX. Now, would you be worried about fitting a patient that's a 39 diopter radius and a 0.3 eccentricity with a -1 refraction? No, you wouldn't, but a -6, that's a pretty tough go. So you're warned up front. What is an easy patient? What is a difficult patient? Guided by these analyses. Another thing that we use, not so much from a candidacy perspective, but from a customization consideration, is what is the visible iris diameter? And we really want to think about being about visible iris diameter minus 0.5, some manufacturers recommend, others maybe minus 0.8. So if you have an 11.4 visible iris diameter, my thinking is I would subtract 0.8. We would fit this patient with a 10.6 diameter lens. Consider that these lenses are meant to work in the closed eye environment, and we want them to center, we want them to create their hydraulic force centered to the visual axis and the pupil. So if we have too small a lens, it might fit sloppy, it might not center. If we have too large a lens, it might fit too tight, be uncomfortable, it might impinge on the conj. So getting the right diameter, really important. Now, sagittal differential is probably not one that you're familiar with if you're newer to orthokeratology and maybe also rigid contact lenses. Sagittal differential determines the height difference between the flat meridian in microns versus the steep meridian. And the difference between them is the height change between your flat and steep axes. And ultimately, what it's telling you is the toricity of the peripheral cornea as opposed to the central corneal astigmatism. It's telling you where the lens will land down, how much toricity exists there, and therefore, do I need a symmetric landing ortho-K lens, or should I be fitting a toric? Any patient that's 30 microns or greater of sagittal differential, that's the threshold where we use at Pacific University, where we would fit a toric. And many manufacturers use that threshold as their guide of, do I go symmetric, spherical landing on the patient, or do I go toric? Do I have 2 meridians of depth? So this is a really important one because 1 in 3 patients that you'll fit meet that threshold. So 1 in 3 patients should be wearing a toric lens. So that's quite a high percentage. Now, corneal displacement is another one that you can look at before you begin treatment. And what I want you to envision in this topography is look at those hot contours. What direction are they pulled? Are they pulled superior? And I don't mean the apex, the steepest portion. Look at the yellow-green border toward that periphery. And I've tried to draw a circle that would best align to those contours. And what you might agree with me is that this eye appears to have its contours pulled a little bit inferior and a little bit temporal on this right eye. So before I start ortho-K, I know that the lens is likely to have some slight displacement. You know, if the cornea is pulled down and out, that's where the lens is going to want to go. It's going to find its equilibrium on that green-yellow shape that you see toward the periphery. So all of these things we can learn before we've even placed the lens on the patient. We've got a really good sense of the candidacy and what direction this treatment is going to go. Now, the great news about Ortho-K is you have a whole range of options to fit orthokeratology lenses. You can just take your topography data and send it off to the lab, and they can empirically order the lens for you, send you back a lens. You can use a trial set if you prefer to put a lens on eye, give the patient some idea of how this process feels and what's involved, and then it gives you an idea of the fit of the lens. Some prefer an inventory where they have a massive number of lenses and they can pull another lens out of the set if they don't like the fit of the initial lens. Some prefer the customization of corneal topography software or taking the topography data and importing it in to a third-party software. So the good news is all of these systems work and they all work fabulously. So you just need to choose which one or which ones are best for your practice and your fitting philosophy. And personally, I use a number of these options because one size does not fit all. One lens does not work for every patient. So it's good to have a few in your arsenal. Now, I'll talk just briefly about topography derived because it'll help you get a sense of what's underneath that lens and how it works. What you need to become the master of in orthokeratology is this tear layer profile you see down here. And this is telling you the thickness of fluid at the apex, the thickness of fluid at the reservoir. That's this area here where the fluorescein looks thick or deep. Then you have your alignment zone, then you have your edge lift. So understanding this profile is everything in orthokeratology lenses. Now, let's concentrate on that blue line, the flat meridian. And what you see on the graph down below is my lens is approximately 5 microns above the apex of the cornea. So I have that tiny, tiny little fluid layer. But then as we go toward the optic zone junction, around 6 millimeters, you notice the thickness of fluid is much, much thicker. And it's this difference between the fluid layer in the center and the fluid layer in the mid-periphery that creates the hydraulic effect. It creates the orthokeratology effect. So the deeper that reservoir is relative to the apical clearance, the higher the suction force, the higher the treatment that you can create. And that's why a low RX just needs a slightly flatter base curve to cornea relationship. A 6 diopter will need a much flatter base curve to cornea relationship. Now, maybe the most important part of an ortho-K lens is this alignment zone right here. I believe without that a proper alignment, we don't have centration, we don't have comfort, we don't have a healthy physiologic response. So these are all super important. What I'm happy that I'm seeing is good alignment at 3 and 9 o'clock to keep the lens locked onto center. And then I've trapped in that fluid layer in the center. That's optimal. Now let's go to the steep axis. Now the red line running vertical, let's understand the fluid layer underneath. And this isn't looking so good. Notice your fluid is getting thicker and thicker and thicker. The alignment zone is in no position to be keeping that lens on center. It's going to allow the lens to rock back and forth with the blink. In the closed eye environment, the lid's probably just going to pull that lens up. This is not a healthy, not an optimal relationship along the steep axis. So what we are learning is that an ortho-K lens needs to align both across the horizontal, but have an appropriate relationship along the steep axis, in this case, the vertical. So let's reconstruct. Remember, this patient has 36 microns of sagittal differential. And we said that a patient with 30 microns or greater should be in a toric. So let's design a toric. Again, across the flat, we'll have our lens land down at 3 and 9 o'clock with this healthy fluid layer in between. Then we're going to go to the steep axis and we're going to create a much deeper relationship. Our reverse curve will be steeper, will be higher, will be deeper. It will move the alignment toward the surface so that that lens doesn't have that much room to rock back and forth. We're going to have a much more stable relationship between the lens and the cornea. So this is the goal of every ortho-K lens, regardless of the system that you used. We're looking at topography derived right now, but literally this is the philosophy of fitting every ortho-K lens, whether it's an empirical or a software derived. And ultimately, what we want to do is arrive at the right parameters the first time. Imagine if you and I get the parameters wrong and We bring the patient in for that dispensing visit. Looks okay. We're thinking maybe we'll send them home with the lens. So now we're guaranteed we have 2 visits. And if that lens doesn't perform in the closed eye environment, we've just wasted 2 visits with the patient, 2 chair time visits. So important that we get things right. Now, one of the great things about topography being digital is that we can now easily share information with the lab. So if you're brand new to orthokeratology and designing a lens by that tier layer profile seems kind of intimidating, that's okay, because you can just export the raw data to the lab. They import it into their software. They can construct the lens for us. So this is a very helpful tool when you're starting out, because you don't have all the experience you need in the beginning. It's nice to be able to rely on experts. Now let's assume that we've had our lens ordered, we pulled our lens out of our diagnostic set. However it is, we are beginning treatment. We send the patient home with the lens. What do we do next? And of course, the post-treatment visit employs in a comprehensive manner the slit lamp exam, and then we're going to check the visual acuity. You don't really need to do a refraction because the topography will tell you the kind of changes you've created, and we'll explain that in a second. But ultimately, out of this collection of analyses that we might do, I would argue that topography is the most important part of your post-treatment analysis. It kind of tells you the big picture. Now, for sure, we care about whether the eye has any staining, if there's any physiologic concerns, no question. We are concerned with the patient's vision and their quality of life from orthokeratology. But so many things we learn from what we actually did to the cornea, and we learn that primarily from the topographer. So there's 2 ways that you will assess the post-treatment outcome. One is the axial map, one is the tangential map, and they come in many different names, but every topographer does an axial and every topographer does a tangential. Again, it might be termed differently, but you'll be able to figure that out with your manufacturer. Now, one thing that you should never do is look at these 2 maps by themselves. And what I mean by that is, here is the post-treatment on this patient that we've just evaluated. We looked at the baseline maps for this patient. Now here are the post-treatment. And I am looking at just the axial map on the left and just the tangential post-treatment on the right. This is not how you assess orthokeratology. You use what's called the subtractive map, also known by some topographers as the difference map or the comparison map. And they all do the same thing. They compare pre-treatment versus post-treatment to give you the difference. So A minus B equals C. It's subtracting the thousands of data points that you had before treatment from the thousands of data points post-treatment to tell you how you've changed. One of my mentors in orthokeratology and topography, John Mountford, he says that the post-treatment map is what the cornea is, but it doesn't tell you how the cornea has changed. The subtractive map tells you what movement has taken place and what effects have you created for the patient. So this is one that you must learn how to use. Every topographer will have, or virtually every topographer has this function. Talk to your manufacturer, your distributor of the instrument, and determine how you get access to selecting pre-treatment, post-treatment, and the difference in an axial and a tangential interpretation. Once you have access to this, you have so much information. The axial map tells us 4 very important things: the RX change, the treatment zone position, the treatment zone size, and gives us perspective on its myopia controlling shape, whether we are creating an ideal myopia control outcome. The tangential map tells us one thing, but one thing only: What is the position of the lens in the closed eye environment? We use both those interpretations, both those analyses, to understand whether we are going down the right path in Ortho-K. They tell us what modifications that we need to make. They're so important to our understanding of whether we're doing it right, whether there are changes we can make, whether there's improvements that can be done. Now, when we do orthokeratology and we use the subtractive map, there are 5 different outcomes that you might encounter. The bullseye, meaning we did it right. The central island, meaning it's a little bit steep. The frowny face, meaning the alignment zone is a little on the tight side. The smiley face, meaning the lens is riding high. And the lateral displacement, meaning it's going nasal or temporal. So these 5 topographical outcomes are determined using the subtractive map. So again, you have to find out where you get access to this, because it's going to be your guide of how good or how poor our Ortho-K treatment is. Now let's look at our patient that we've started this process with. We have our baseline up here, our post-treatment here, our subtractive map is on the right-hand side, the difference map. And after one night effect, we are going to pull this up and determine how are we doing. So I'm going to start with the axial interpretation. I might begin by clicking my cursor right on the center of the map and determining how much RX change did we create. So we don't have to do a refraction, because the change in apical corneal power from steep to flatter, that radius change can be determined by the topographer. So you don't need to do a refraction. The map will give you excellent perspective on the refractive change. In this case, 1.74 diopters, 1 3/4 diopters flattening, 1 3/4 diopters myopic reduction in one night. Next, we could look at the treatment zone position by following the blue of that area of central flattening. Where is that treatment zone in relationship to the visual axis and the pupil? In this case, pretty well centered. Next, we could look at the treatment zone size, and that's measured from 0 to 0, where you're creating basically no change in effect. So you'll notice that we had flattening in the center, and then that flattening gradiates out, and where the curvature reaches the same point that the patient started with, so basically no change at that point, that's where the end of the treatment zone is. Or thought another way, maybe more simplified, it's basically blue to blue is the treatment zone size. That's a kind of a rough estimate of what you're dealing with. Then one of the most important things that we assess in topography, and one of the newest analyses as well, is what we call at Pacific University the Myopia Defocus dosage. And we're trying to determine, are we pushing enough signal to slow down eye growth? And what you're going to do is click your cursor on the center of the axial subtractive map. We're creating about 1.77 diopters of effect. Then we go to the pupil border around 5 millimeters, and we measure a 0.22 diopter RX change. So here in the center, 1.77 diopters. Here on the border of the pupil at 5 millimeters diameter, we're getting 0.22 diopters effect. The difference between them is a 1.5 diopters, or 1.55. So what are we saying here? That from the center of the topography to the periphery, you're creating what you might call as an add in a multifocal soft lens. You're creating that defocus, that add power in the pupillary zone to push to the retina and send that signal to slow down eye growth. So we want that myopia defocus dosage to be as high as it possibly can be. Would you fit a kid in myopia control with a soft multifocal lens that's an add of only +1? No, you would want to push the maximum add possible to send the strongest signal to the eye. So 1.5 diopters might be kind of the minimum that we would like to see for myopia control. Preferably, I'd like to be at 2 or even higher. So this is a very important analysis that we do. Now, the tangential map, we said, tells us only one thing, but it tells us one very important thing. Where is the position of the lens in the closed eye environment? So if you follow this red ring that is defining where the suction force of the ortho-K lens is, where that reservoir is pulling on the epithelium, you see that those arcs that are there, creating that central concentric red ring. And that is telling you exactly where the lens is positioned. Now, would you agree with me that it's maybe on this right eye a little bit temporal, and that black circle is looking like it's a little bit inferior? And wasn't that what we predicted in the baseline map, that the contours of the pre-fitting cornea were kind of pulled temporal and inferior? It's exactly where the lens is going. This is a beautiful outcome. This is a beautiful centered bullseye, but if you argue anything about centration, it's slightly temporal, slightly inferior. So we get a really good sense from this subtractive map in both the axial and the tangential, what is going on when the patient closes their eye over that lens, and we have that sustained 8 hours, 10 hours, however many hours of sleep. We get a really good idea of what's going on underneath that lens, changing the epithelium. Now, ultimately, this lens that we use as a tool to manipulate epithelium, I don't know if you would agree with me, but looking at this fluorescein pattern, can you say that this is going to create an ideal outcome? Looks okay. I mean, the lens appears to have touch in the center, and we know we don't want orthokeratology lenses to bear on the central epithelium. They're supposed to use hydraulic force. We know we want this reservoir, so that's good. Doesn't look super deep to me, but it looks okay. It looks like we have alignment 360 degrees around. That's optimal. And it looks like we have edge lift 360 degrees around, maybe a little bit thicker here, a little wider than we'd like. What is this lens going to do in the closed eye environment? Who knows? And that's why topography is so valuable to you, because it's going to give you not only the initial lens parameters, but it's also going to tell you, what did this lens do when the patient closed their eye over this contact lens for sustained, sleep? Now, what creates the topographic changes that we've talked about? In the center, where the lens is close to the cornea, and you have that maybe 5 microns or 7 microns or 10 microns of fluid, underneath the center right here, you get a hydraulic compressive force. That tiny little fluid layer is trying to be equal to the thickness that you see right here in the deepest part of the reservoir. So you get a central push force on the axial map that gives us this blue treatment zone. So on the axial map, you look into the center of the topography. You're concentrated on the blue central effects. Conversely, when we go over to the tangential map, we ignore what goes on in the center. We're concentrated on this red ring and where the reservoir was that's pulling on the epithelium. This deep fluid layer is what's creating the red. And then just going a little outside of there, the blue that you see here is created by the alignment zone. This is the only, I'll repeat that. This is the only part of an ortho-K lens that should physically touch down on the eye and create a mechanical molding of the epithelial surface. Everything inside of that blue ring is hydraulic. You're manipulating the fluid layer. So the one night effect is, it certainly gives you perspective on whether you're going the right direction. It's going to decide for us, do we continue treatment after one night, or do we see something that is highly concerning and we're going to just take this patient out of lenses and refit? But don't rush to conclusions. If you think you're on the right track, just keep going. Remember that Ortho-K's full effect is 7 to 10 days. So after only one night, you may only be seeing partial topographic changes. And similarly, the visual change is only going to be a certain percentage, maybe 70%. So don't rush to conclusions. If things are looking okay, patient isn't uncomfortable, they were able to manage the overnight wear, the slit lamp findings aren't really concerning, then just keep on going. And this is the patient after 8 nights. And you'll notice that the blue treatment zone is filling in nicely. The longer we give these lenses their time to do what they're meant to do, the smoother the cornea gets, the better the quality of vision the patient has in the AM. And as that effect begins to wear off over the course of the day, their PM vision is also improved. So let them go longer and things kind of prove themselves out. Here's our tangential map, beautiful red ring, maybe a little bit inferior, but we knew before we started that the contours of this eye were pulled inferior, if anything. So this is kind of helpful because the baseline map will tell you if your eye is displaced kind of laterally, that's where the Ortho-K lens is going to go. There's almost no point in trying to modify it because you'd be fighting nature to try to drag the lens onto center to fight the natural displacement of the cornea. So this tool is so important to the treatment, and maybe why Stephanie wanted to expose you to a little bit of corneal topography, because it's such a big part of orthokeratology treatment. You know, it determines the candidacy. It determines the initial lens parameters. It determines the post-treatment outcome and what changes that you make. You know, the topographer is, at least relative to orthokeratology, the most important tool that we use with these myopia control lenses. Now, what are some recommendations that you might take back to practice when you start orthokeratology, or even if you're doing it now? What are some of the things that we really want to embed into our practice? Like Nick had explained to us, there are things that just must be part of the way that we approach this treatment. Now, the accuracy of an Ortho-K lens needs to be higher than any other product that you fit. There is no other contact lens that requires the level of micron preciseness that Ortho-K does. As an example, an ideal Ortho-K lens should be about 5 to 10 microns away from the eye. 5 to 10 microns. A tiny, tiny amount of fluid needs to exist between the epithelial surface and the back of the contact lens. If you miss by only a few microns, that could be a lens that hits the central cornea. If it hits the central cornea, we're going to have staining. If it hits the central cornea, the lens is going to decenter. If it's unstable, it's going to be uncomfortable. So we have to nail down the height accurately. Another thing that we must do is we've got to get that alignment correct. Remember in the beginning, I said, personally, I think the alignment zone is the most important part of an Ortho-K lens, and getting that surface relationship to be appropriate improves centration, stability, comfort, and effect. So we've got to get all of these things right from the topography. So the most important person in orthokeratology in your practice, I'm sorry, is not you. It's the person who takes the topography. It's your technician. They determine the success of treatment, because if the initial topography is erroneous, then we head down a path that results in multiple visits for you and the patient. The efficiency of this procedure is determined by this this staff member of yours. The post-wear analysis is determined by this technician in your practice. So whether it's you taking the topographies or your assistants, they need to understand how important their role is. And it's not just snapping a photo. We need a photo that's going to be so precise that we can build a lens that is 5 microns away from the eye, or 7 or 10. So the way to take really good topography is get the lids and lashes open as much as you possibly can. This is my daughter, and I can't get her to open up much wider than this, but try as you might to get your patients to open up as wide as they possibly can. Some of the tricks that you can try is to pull down on the lid, and that will expose a little bit more of the cornea. As an example, we want to understand the kind of toricity this lens needs. And with this topography, I've got lids blocking a good 30% of the superior cornea, maybe 10% of the inferior cornea. I've got eyelash shadows coming down. So I've got to find a way to get this patient to open up. You heard Nick talk about using a Q-tip to just move the upper lid out of the way. Be careful when you do that, that you allow the patient to maintain normal tear exchange, especially if it's a reflection-based topographer, but very good method for trying to get more coverage. I couldn't agree with Nick more. Do everything you can to get good topography. If you're using a reflection-based topographer, meaning you're reflecting light off the corneal surface, measuring it as it comes back, using a placido like this, for instance, where you have tear film breakup right here, notice how multiple rings are collapsing on each other. These rings are distorting. Most concerning are the central rings aren't completely clear and running parallel to each other. The topographer begins by understanding the center, and then it moves its analysis out toward the periphery. So the more accurate the center, the more accurate the entire topography. So if you have tear film breakup near the center or within the central 10 or 15 rings, that potentially could create a very erroneous topography and send you down the wrong path. So I can't emphasize this enough, how important quality baseline topography is. Now, when you get a good map, it's pretty obvious you've got lids and lashes out of the way. You've pushed that reflection or the analysis to the far periphery of the cornea. But then when you look at the topography itself, you should see very smooth transition from steepest to flattest. And what I mean by that is you don't see a hot spot immediately next to a cold spot. You see this very gradual change from steepest to flattest. Each one of those contours is very well rounded. You don't see any sharp points. You don't see a sudden island next to a sudden depression. I believe this is an accurate map because it looks so smooth to me. But I'm never 100% sure. So the way you provide yourself a little more confidence is to take multiple readings for your baseline topography. So talking purely about pre-treatment. Take multiple maps. If they all look reproducible, if they look identical, then you have confidence that you have accuracy. If you have the ability to do multiple fixations and merge them together to create a larger view, this is the way I would do all of my baseline topography. Now, some of the considerations related to shape that we haven't talked about are the astigmatic eyes. And spherical cornea is generally pretty straightforward cases. Stigmatic eyes, there's a few more considerations. When you have an apical astigmatism, you generally see the figure eight or hourglass shape confined to the center of the eye with green 360 degrees around. Look at this green here. The peripheral cornea is essentially spherical or non-toric. These eyes respond very well to orthokeratology treatment. You can push most of the astigmatism out of the way. When you have limbus to limbus astigmatism, where the hot contours run from one side of the eye to the other, these are eyes that are more challenging to push the astigmatism out of the way. So you are aware before you begin treatment that this patient may have some residual cyl left over. I wouldn't be afraid to try Ortho-K on this patient, but I would be forewarned that if we undertake Ortho-K, astigmatism could be a struggle for this patient. So if the patient is really sensitive to the astigmatic part of the refraction, then yeah, maybe I'm thinking that Ortho-K might not be the tool I'm going to use. Another topographical consideration is the displaced apexes. And you can see in this patient, the contours are all really pulled inferior and temporal. So I know that lens is going to really decenter on that patient. I'm not afraid to try Ortho-K on this person, but I know before I begin that centration will be a challenge. The good news is that orthokeratology that decenters more actually creates better myopia control. In other words, we kind of target having the treatment really well onto the center of the pupil and the visual axis. And that's always provided the least aberrations, the best quality of vision to Ortho-K patients. But recent research has shown us that the smaller the treatment zone and the more it decenters, the better the myopia control. So if the patient has a decentered treatment zone, but good quality of vision, then I'm not too worried about it. If the patient has a decentered treatment zone and they are struggling with the aberrations, then we have to find a way to try to fix that. But it's helpful to know that you can look at these baseline topographies and get a sense of whether I'm going to need to refit that patient when they come back with a decentered apex. And if the cornea is clear, if the patient is visually happy, then I'm just going to leave a decentered treatment zone because I know it's actually going to produce better myopia control. Now, the data collection we talked about, this can be kind of challenging, and you might find that your lab can be helpful because they're experts at virtually every topographer, but definitely the topography company is a good place to start. So once you know which design that you're going to use, find out from the manufacturer what data do I need from my topographer, and then your topography company might be helpful as a way of determining where do you find it in the software, because sometimes it's embedded. It may not be so obvious on your main window. That ability to share digital data, boy, this is so important, especially to the neophyte orthokeratologist. I know personally I made huge mistakes when I started orthokeratology by assuming that I had a poor outcome when really I had a optimal bullseye. It just needed more time to create its effect. And if you're not sure, it's nice to have the lab expert back you up. Yeah, just continue with where. Or if you don't feel comfortable with designing the initial lens parameters, start with a system that's more empirical, that allows you to fire the topography off to the lab. They can construct the lens for you. You've got to learn how to use this subtractive map. If you're not using this, you're missing information. You're not getting the full picture. So determine how you get access to this. How do you select baseline and post-treatment, pull up the difference map, switch from axial to tangential so you can get all of this wide perspective that you get from the subtractive map. Such an important function in orthokeratology. It's also useful in understanding refractive surgery, comparing pre-surgery shape to post-surgical shape. You can have an appreciation for the type of outcome that the LASIK surgeon has created for the patient. We can use the subtractive maps to follow keratoconic patients over time. Are we seeing changes? So the subtractive map is really a useful tool for more than just orthokeratology. Now, the tangential map, we said that its value is to determine the position of the lens in the closed eye environment. Follow this red ring. in relationship to the visual axis on the center, or if there's a pupil defined, where is the pupil in relationship to this red ring. Sometimes the red ring is not so defined after one night. Sometimes you might see an arc here, another arc here, another arc up here. You don't really see a completely concentric red ring. Then go outside of that, go to the blue ring where the lens touches itself down on the eye surface. So those two rings, the red and the blue on the tangential map, can really guide your treatment. The axial map, we said, tells us many, many things. When we focus in on this area of the graph down below, on the 5 mm pupil, what is the apical change? What's the maximum effect in the center? Then what is the effect at the border of the pupil? So what is my flattening centrally compared to what is my flattening at the end of the treatment zone, or really where the pupil border is ultimately where we want to be. And that difference between them is our signal to slow down eye growth. How much add have we created? Some research calls it the power shift. We call it the myopia defocus dosage. What amount of signal are we sending to the back of the eye? And if I feel like I'm only creating a low amount of plus power, a low amount of difference, or myopia defocus dosage, we're going to manipulate the lens parameters to try to decrease the treatment zone, increase the spherical aberration, increase this plus power that's being created. So even before we've sent the patient off for their next visit, which might be months down the road, we kind of have a sense, have we created, number one, a good bullseye, but have we, number two, created a good myopia controlling bullseye? Also important. Now, don't rush to conclusions. If I could share with you one of my principal mistakes in the beginning of orthokeratology, I think I was looking for the topography to give me the definitive story after one day. But ortho-K lenses take about a week to 2 weeks to create their full effect. Whatever lens you put on eye will only show you its truth after about a week to 2 weeks of wear. So start out, and if the map looks okay, just continue and see the patient after you've let that lens create more effect on the epithelium. Generally, though, you get a really good idea after one night if you're off on the right path. The consultant, such an important part of the process to assist you with the lens construction, and maybe most importantly to assist you with the post-treatment and what changes are necessary in Ortho-K. Once you become a master of these subtractive maps, boy, you're really going to be able to determine your own changes to the lenses. You know that a high riding lens is loose, and we're going to manipulate the alignment zone. There's a lot of tools out there that are specific to this topic, that are utterly devoted to how do you assess the baseline map? How do you assess the post-treatment map? They're either online with the manufacturers, with the associations. You've got lots of options out there. So just to kind of finish up, I'm going to whip through a few cases. If you know that you have bullseye, central island, smiley face, frowny face, lateral decentration, what would you call this outcome here? Look at your blue treatment zone in relationship to the pupil. Pretty well centered, would you agree? Let's switch over to the tangential. We see a red ring, very well centered to the black pupil margin. If anything on this right eye, it's maybe a little bit temporal, but this is beautiful centration. This is what you call the bullseye. This is the goal of orthokeratology treatment. It tells you you've done basically everything right. This, much different in appearance. Notice the hot in the center, that steepening you have at the apex. When you look at the blue treatment zone, that white circle, looks like the lens is maybe a little bit on the low side. we go to a tangential map. Again, ignore what's in the center. Look at the red ring. Notice how low it is in relationship to the black pupil and the visual axis here on the center. This is what you call the central island. This is where your lens is too far off the central corneal apex. It pulls the epithelium up in the center instead of flattening it out. Central islands are also caused by tight alignment zones and lenses too large. So if you see the central island, you know exactly what to do. You essentially have too steep a lens. Here we see one that comes up with great frequency where the blue treatment zone is decentered where in relationship to the pupil. Notice how that blue treatment zone is riding high in relationship to the black pupil, giving you a inferior smile. And then when we switch to the tangential map, you notice the red ring is well inside the inferior pupil, slightly above the superior pupil. So we have what's called the smiley face outcome. The lens is riding high. We need to tighten up the alignment zone, neutralize the lid force so the lens can come down. Then the opposite to the smiley face, where you see a frown and a blue treatment zone decentered low. This is a tight fitting lens, also backed up by the red ring you see here, decentered inferior in relationship to our pupil. So opposite to the smiley face, the frowny face is a alignment zone that's too tight. It's squeezing too much, causing the lens to ride low. The good news is both the smiley face and frowny face provide good quality of vision in the morning, but if you see a very quick loss in effect over the course of the day or the PM vision is poor, then you know you need to make adjustments. Finally, lateral displacement is one that I don't see this too often, but it does come up it will come up in treatment. And there you're seeing a blue treatment zone, radically decentered nasal or temporal, and the tangential map backing up that ring is decentered one way or the other. These are generally resolved with larger, with tighter, more toricity, some way of trying to better lock down the periphery of the lens. So guys, get to become an expert at these analyses. Post-treatment, is it a bullseye, central island, smiley face, frowny face, or is it laterally decentered? And it will tell you what you need to do in modifying lens parameters. Hey, so I hope this session has had some value. I'll maybe open it back up to Steph.